T helper cell subsets is good in terms of providing a balanced immune system development. You also see an increase in the innate immune capacity. So the immune cells that are there, like macrophages and neutrophils, that are really interacting with the pathogens for clearance, their capacity to be able to interact with those really increases early on in life. And this contributes to the immune system of the newborn. The development of tolerance is absolutely crucial to be able to tolerate the food antigens that the baby's exposed to early on in life. And we know that this decrease in T regulatory cells happen while this oral tolerance is actually being inducted. So if we move on then to the next slide, you will see that just like lots of things influence the immune system development while the baby's in the womb, once the baby's born, there are also a plethora of things that influence the immune system development. Some of them are environmental, but some of them are to do with the mode of delivery, the maternal factors that influence the baby while it was in the womb, the mode of feeding, whether it's breast milk or bottle fed, and early exposure to antibiotics, such that can happen with preterm infants who are more susceptible to infections early on in life. The microbiome is a huge influencing factor in terms of immune development and indeed oral tolerance. And we know that microbiome factors can be influenced again by lots of these individual factors very early on in life. The microbiome is in the gut. 70% of your immune system is in the gut. There is a really clear relationship between the two of those, and they are influenced by all of these different factors that are here on this slide. So there's lots going on very early on in the immune system development in a baby. So if we move on then to look at allergy, so we need to understand what allergy is, and more importantly, we need to understand what was the breakdown in the immune system that led to the development of an allergic response. What was the mechanism that failed in some way to be able to develop an allergy? So 20 to 30% of children are affected by what we call atopic disease, which will give them a predisposition to an allergic response, whether that's atopic eczema, whether it's a food allergy, or things like asthma and rhinitis. So they are very highly prevalent in small infants. If we look specifically at food allergies essentially derive from a breakdown of immune tolerance to dietary antigens. So when dietary antigens enter the body, there is a normal process that has to happen that allows the body to tolerate those food antigens. And it is a breakdown in that lack of tolerance that leads to the development of an allergic response. Many children with food allergies naturally outgrow them over time. And in fact, if we look at cow's milk allergy or CMA, hen's egg allergy, and indeed wheat allergy, many of these children, up to 50%, this is resolved in the first few years of life. So without any intervention, these allergic responses will resolve very early on as the immune system develops over time. Other food allergies, which would be more severe allergies like peanut allergy and fish allergies, they have lower rates of resolution and can persist throughout life. So if we look for a moment specifically at cow's milk allergy, it is one of the most common food allergens. It affects about 3% of children less than 1 year of age. And the incidence is highest in children that have a family or a personal history of atopy. So history of asthma, eczema, hay fever, or any food allergies will mean that the baby is at a higher risk of developing one of these allergies, like cow's milk allergy. Most of these are immunoglobulin E, which is IgE mediated, which means that the exposure to the antigen triggers the immediate release of this IgE, which then triggers mast cells to be able to degranulate and to secrete histamine that causes the symptoms of the allergy. And that would happen normally within about 2 hours of them consuming the food antigen, in this case, the cow's milk protein antigen. So then cow's milk allergy, lots of it resolves very early on in life. But if we move on to the next slide and we look at whether there's a long-term consequence, I think it's easy to see why anything that can enhance recovery or anything that can be therapeutic in cow's milk allergy early in life, that there's a real rationale for that. And that rationale lies in the fact that if cow's milk allergy protein is not resolved early on in life, there's actually a 50% chance that these children will go on to develop additional allergies later on in life. So we see from the literature that about 50% of children with cow's milk allergy will go on and develop one other type of atopic disorder later in life. And the three most common of those is eczema, allergy, and allergic rhinitis. So one study showed that these included other food allergies as well, such as egg, soya, peanut, and shellfish in up to 45% of children. So early intervention to manage cow's milk allergy may have long-term consequences by actually preventing the development of other allergies in children. And that's a really good rationale for being able to modulate that response early on in the infant's life. So what's the current approach then to cow's milk allergy? Well, the current approach is very simple. It's complete avoidance. So the rationale there is that if the immune system is responding to the cow's milk protein, then take the cow's milk protein away, and then there will be no immune response. And the way in which that happens is by giving the cow's milk protein in an extensively hydrolyzed fashion. So here the protein is so hydrolyzed that the peptides are so small that the immune system no longer recognizes them and is able to respond to them. And this has been the approach to cow's milk allergy for a very, very long time. The atopic response in an allergic infant, if we just look at that for a moment on the next slide, what we see is that there's a few key things happening here. One of them is that there are low numbers of T regulatory cells in these infants. So they're not getting switching on of T regulatory cells to be able to tolerate the cow's milk protein. The other thing that we see happening in this slide is that they have what we call a dominant Th2 response. So that dominant Th2 response that they were born with from the suppressed maternal environment, they haven't managed to lose that dominant response by switching on other types of Th1 responses, for example, and this Th2 response remains dominant. Th2 cells activate B cells to make antibody, and as we know already, IgE antibody is a key driver of mast cells producing histamine and causing symptoms of allergy. So in atopic infants, you have allergic responses that are predominantly mediated by Th2 cells. And then if we move on to look at what happens in an allergic response in cow's milk allergy, what we see is that the sensitization of the infant to cow's milk protein, that when the milk protein enters into the gut, that the activation of the T cells by a dendritic cell is not a T regulatory cell like it should be for oral tolerance, but in fact it's an activation of a Th2 cell. Those Th2 cells, as you will see, interact with B cells. They instruct B cells to be able to produce antibody, in this case IgE, and that IgE antibody binds to mast cells, they degranulate and cause the symptoms of the allergic response. So this is what happens in cow's milk protein allergy. If we move on then to look at what is supposed to happen in oral tolerance. So what is oral tolerance? What do we understand is important about it? And why does it fail in these infants? And in infants where it's failing, can we intervene and do anything about it? Okay, so that's what we're moving on to next in the presentation. So oral tolerance develops after frequent exposure to food antigens. Upon ingestion, food is digested into small protein fragments in the GI tract. Some can cause allergic immune responses leading to food allergies. But oral tolerance helps to prevent that, helps to prevent the pathological reactions against food antigens. And it does that by involving a number of different immune cells. So dendritic cells are really important, the epithelial cells themselves that line the GI tract, and indeed the gut microbiome and the presence of commensal bacteria. All of these contribute to oral tolerance. A subset of dendritic cells are able to induce these T regulatory cells, so we know they're really important very early on in a newborn's life in terms of oral tolerance. These T regulatory cells are able to secrete anti-inflammatory cytokines that essentially switch off the allergic responses and suppress anything that's happening in the gut, which means that they are now tolerant to those food antigens. T regulatory cells are absolutely critical in oral tolerance. So moving on, just like all of the other factors that we've discussed are influenced very easily by external factors and nutritional factors, so too is oral tolerance. Oral tolerance has a number of factors from the individual or the host factors, and they impact on oral tolerance. So the immune cells that are present in the gut, the physical barriers that are in the gut, and the digestive process itself. If we look at environmental factors, key ones here are about the mode of feeding, breastfed versus bottle-fed, the time of introduction of solid foods, and how the microbiome has developed in that individual. And then finally, the immune factors themselves. So the immune regulatory factors, the T cells, the dendritic cells, and the cytokines that are secreted locally in the gut when you are trying to induce oral tolerance. So if we move on to the next slide, which is about these T regulatory cells. Now, orally induced T regulatory cells are absolutely critical to the induction of oral tolerance. You'll see from this slide that tolerogenic DCs, which are activated by the food antigens that enter the gut, their job is to interact with naive T cells and drive them into T cell subsets that are able to mediate oral tolerance. There are 3 of these different subsets, and you'll see on this slide that there are 3 different types of T regulatory cell: TR1, LAP Tregs, and FOXP3 positive Tregs. Each of those plays a role in oral tolerance. And while they all have slightly different functions and are all activated in a slightly different manner, one of the common things that they all do is they all secrete anti-inflammatory cytokines. And the role of these anti-inflammatory cytokines is to create a suppressive environment in the gut so that antigens that go into the gut can be tolerated by the immune system in the gut. So let's look at oral tolerance development in an infant. One of the key things that happens involves tolerogenic dendritic cells. The role of a dendritic cell is to pick up antigens entering the body, be able to process those antigens and present them to T cells. Okay, so this is the normal role of a dendritic cell. Tolerogenic dendritic cells that are found in the gut are exposed to food antigens. And those food antigens can move through the gut wall, through the physical barrier, those epithelial cells, and that's facilitated by goblet cells. And once those food antigens move through that gut barrier, they're taken up by a dendritic cell, they're processed, and they are presented to local T cells in the Peyer's patches. And these are immune important sites in the gut where T cell activation takes place. So the tolerogenic dendritic cells, they interact with T cells in the Peyer's patch, and depending on what the dendritic cell has been exposed to and what that dendritic cell is actually secreting, it will switch on one of the 3 subsets of these T regulatory cells. So we'll see from this slide, we have the TR1 cells, FOXP3 cells, and LAP. And the 3 differentiating factors of switching on these cells is what the dendritic cell is secreting. So just as one example from this slide, you'll see in the Peyer's patch there that the interaction of the dendritic cell that produces IL-27, that drives TR1 cell differentiation. You'll see if it's producing TGF-beta and IL-10, it's driving LAP. And those cells leave the Peyer's patch once they've been switched on. They go to the site in the gut and they expand. In other words, they proliferate and they make more of themselves. So all of these cells that are switched on in the Peyer's patches, all these tolerogenic T cells, these T regulatory cells, move out of the Peyer's patch into the gut. They produce anti-inflammatory cytokines and they create a suppressed environment in the gut so that the food antigens are not causing any reaction in the gut. Okay, so this suppressive environment is created by these T regulatory cells, and this is induction of oral tolerance. So moving on then to the next part of the talk, which is about looking at HMOs and oral tolerance. So what role can HMOs play in the gut? What can they do in oral tolerance? What can they do in allergy? So first of all, HMOs, our maternal milk, as we know, contains many different components that impact on the immunity development in an infant. And HMOs are a significant part of this. They're synthesized in the mammary glands from lactose, and they are the 3rd most abundant solid component in breast milk. They can deflect adhesion of undesirable microorganisms to intestinal cells. In other words, they can actually stop the binding of pathogens to intestinal cells to actually cause infection in the gut. So they're really powerful in terms of maintaining homeostasis in the gut. They can also specifically inhibit the growth and production of biofilm from Streptococcus group B. So they're extremely important early on in life in being able to prevent infection in the GI tract of a baby. Interestingly, one of the other things that can happen is that HMOs serve as prebiotics. And what that means is that they serve as a substrate for commensal bacteria that are found in the gut. So the HMOs can be broken down by the commensal bacteria. They can create and produce metabolites like short-chain fatty acids, and they indirectly have another role in the gut. And indirectly, they can also create an ecological niche that can resist colonization by pathogenic microorganisms. So not just the HMOs are able to block pathogens from binding to intestinal cells and being able to cause infection, they also are broken down by, serve as prebiotics and are broken down in the gut to short-chain fatty acids, which can also, again, prevent pathogens from being able to infect in the gut. So they're a really good anti-infective agent very, very early on in life. So how do HMOs work? So there's lots of different things that HMOs can do, but what might they be able to do that might be able to influence or prevent allergic responses? So if we look at this slide here, we'll see there's 4 key activities on this slide, and HMOs can do all of them. So the first one is that they have these prebiotic effects. So as I've said already, they're broken down to short-chain fatty acids, and they're able to prevent and block pathogens from being able to infect locally in the GI tract. The other thing that they can do is that they can stimulate the production of mucus locally, and that mucus forms a layer on the intestinal epithelial cells and again blocks pathogens from being able to bind. Indirectly, they can actually interact with immune cells, and this is a really important differentiation factor between HMOs and other oligosaccharides that we might look at, and that's because they can directly have effects on immune cells, and we know that they can impact on dendritic cells and the type of T cells that they then induce afterwards. And then finally, you will see that sometimes they're actually taken into the gut and actually transported into the bloodstream and circulate around the body again as anti-infective agents. So there's a really broad suite of activities of HMOs in the gut. So let's look particularly at one HMO that has got an awful lot of highlighting over the last few years. There's been lovely literature that's come out for the last few years that's really been able to show very definitively the very, very positive effects of 2FL in immunity, in allergy, in infants, okay? And really for the rest of the talk, we're going to focus on looking at 2FL and looking at some of the key studies that have been able to absolutely prove the beneficial effects of 2FL. And 2FL is a really important HMO for the last few years. So it's quantitatively the most abundant oligosaccharide found in breast milk, in most mothers' breast milk, and we know that this can be influenced by a number of different factors, some of those being genetic factors. We've 2 different studies that we've reviewed here, and one of them is a study that took ex vivo murine colonic segments, so used a mouse model, took segments of the colon, and was able to show that 2FL can modulate gut motility, and that might be potentially useful for being able to manage abdominal discomfort caused by colic or irritable bowel syndrome, or be able to improve feeding tolerance in preterm infants. So gut motility is really important in terms of digestion and moving food along, and 2FL was able to enhance that in this ex vivo model. Then if you look at another mouse model that they use to mimic a really debilitating, sometimes fatal intestinal disease that we find in preterm infants, this necrotizing enterocolitis or NEC, what you see is that 2FL has been shown to be protective against that in this mouse model, and that would have a really good indication about how it might behave in preterm infants where this is a really, really big problem. And then if we move on to clinical findings from 2 other key studies we're going to look at these two studies. So this is the Marriage and the Goldringer study that came out in the last 5 years. What we will see is that the clear objectives of this study were about evaluating the growth and tolerance of infants fed formula with and without this 2FL component, compared with infants that were fed breast milk. So one of the things that they're trying to do in this study all the time is to examine what the profile looks like in a breastfed infant, and whether that profile looks very, very different in a bottle-fed infant, and if that's influenced by the addition of 2FL. So the methods used a prospective, randomized, controlled growth and tolerance study, and the outcome measures were very, very clear. There was 3 of those. One was about growth and tolerance. One was about the absorption of 2FL by looking at 2FL in plasma and in urine and looking at metabolites of 2FL. And then finally, and then really very, very relevant to this talk, is about the markers of immune function. They looked at 10 different markers of immune function. And if we move on to the next slide, we'll be able to see the results of those very clearly. So this slide here, in terms of the study setup, just shows you that the clear comparison here in these studies was about breastfed infants versus formula-fed infants. The breakdown of the infant formula-fed groups were 1 without 2FL, so just regular infant-fed formula. The other 2 had 2 different levels of 2FL. So there was 0.2 grams per litre and 1 gram per litre. So one had 5 times the amount of 2FL than the other one did. If you actually look at both of those studies, they actually had very similar groups, and I'm going to talk about them collectively. So both the Marriage study and the Goldringer study had a setup that looked at plus and minus 2FL at 2 different doses. And if we move on to the next slide, what you'll see is the results from that study, in particularly in terms of the immune components. So this slide here, while it looks a little bit busy, there's a very clear message on this slide, and that is if you look at the gold yellow bar, so the gold bar is what we call the gold standard of breast milk. And that gold standard of breast milk here shows that in these 5 different inflammatory cytokines, that there were differences between the breastfed infants and the formula-fed infants without any 2FL. So on the left, you will see the purple bar, which is the control formula without 2FL, and you will see that as you work your way through those cytokines, they're all at a higher level in the formula-fed infants than they are in the gold breastfed infants. But if you look at the next 2 bars, which are the formula-fed infants with the 2FL added, what you will see is that they start to resemble a lot more like the breastfed infants. There's a reduction in these inflammatory cytokines, and they start to look very much more like breastfed infants than formula-fed infants. And there's been a really significant effect of the addition of 2FL to the infant formula. The other thing you'll note from this slide, which I think is really important, is that the higher amount of 2FL and the lower amount of 2FL, you were able to see a really clear difference between them, showing that there's potentially a dose response in the amount of 2FL, and maybe it points to the fact that a low amount of 2FL is actually just as effective as the higher dose. So that needs to be considered moving forward in terms of the amount that we're able to put in to infant formula. So in summary then, the 2FL was, you know, if we look at its role in allergy, so breastfeeding we know is associated with a reduced risk of atopic disease. HMOs might explain some of that protective benefit, because when we add 2FL back into infant formula, we start to see really, really positive effects. So the preclinical data would suggest that it's able to reduce food allergy symptoms by the addition of the 2FL, show that it's able to reduce allergic inflammation, modulates gut motility, and promotes this regulatory, tolerogenic, anti-inflammatory environment in the gut. And that's kind of where some of the data has shown the 2FL to be very, very effective. If we look at a couple of specific studies that look at the HMOs specifically in allergy models in mice, this one here, this study here, so it's Liu et al. What we see is that we're looking at a very specific allergic mouse model, which is that the allergy is in response to the beta lactoglobulin found in the milk protein. And what you see is, if you just look at the graph, that A is the group and the amount of IgE, which we know is produced during allergy. The IgE response here is very high in the mice that were given the allergic response. And importantly, when we look at the next bar, which is the HMO, we show that the amount of IgE is drastically reduced, showing that the HMO is very anti-allergenic. The L, M, and H are specifically 2FL, and again, increasing concentrations of 2FL, showing that even though HMOs have this really good effect, that one particular HMO on its own, this 2FL, is able to give you this really good dose response where you're able to decrease the amount of IgE being produced over time. And if we look at the next slide, which is again another mouse model using these HMOs, we see that in this case it's an OVA mouse model, so the allergic reaction is in response to a different protein. And again, what we see is that these mice have been given the HMO over the period of a few days after the induction of the allergic responses. And what we see, if you look across these three different readouts, one of the, there's two very important ones here that I'll point out. The first is the diarrhea severity, which is a real symptom of food allergy. And if you look at the group, which is the third one down, the upside down triangles, you'll see the OVA 2FL group have a very low incidence of severity, much lower than all the rest of the group. So there is a real impact of the 2FL on allergic symptoms in this model. And then finally, if you look over to the right-hand side of the slide, you'll see that the MCP1, which is an indication of mast cell activation and numbers of mast cells, again, you'll see 2FL is able to reduce that drastically, showing that there's a direct effect on the cell type that actually produces the histamine that induces the symptoms of allergy. So a really, really clear study that shows that the HMOs, particularly 2FL, is able to switch off allergic responses. The other interesting factor about all of these HMOs is that in order for them to be able to be used in a CMA situation, one of the things that needs to be confirmed is that they are hypoallergenic themselves. Okay, so in order to have the additional effects of HMOs, what would be really great is to make a hyperallergenic, extensively hydrolyzed infant formula which has HMOs, so that you're able to do the avoidance of switching on of the allergic responses, and the HMOs are able to do the immunomodulation, which actually directs the immune system to be able to develop oral tolerance and suppress allergy. So there's two studies here that I wanted to point out. One of them is looking at extensively hydrolyzed formula. It was supplemented with the HMOs, and it was well tolerated by infants with CMA. And in fact, the HMOs that were used in this situation were a combination of 2FL and LNNT. So they met the criteria for hyperallergenicity, which means they can be used in infants and children with CMA. But importantly, the 2FL and LNNT that are in there are also able to modulate the immune response in the gut, as well as the extensively hydrolyzed formula being hypoallergenic. The second study, very, very similar, was able to investigate if the extensively hydrolyzed formula with the 2FL HMO was tolerated, and it was. And then that led to the outcome, which was that the casein-based EHF, well tolerated, safe, and again, supported the growth in infants with suspected CMA. So here we are moving to finding extensively hydrolyzed formula that are fortified with these HMOs that are able to avoid allergic reactions, but also modulate the immune system to develop oral tolerance in these infants that are suspected with CMA or at high risk of developing CMA. So just to summarize, promoting oral tolerance can indeed be a therapeutic strategy for food allergy. And we've seen all of the preclinical evidence really points to that very, very clearly. The potential for HMOs, and particularly 2FL, is significant and also very exciting. We need to understand more about how they interact with the immune system. So we know a lot about HMOs in the immune system, but we need to understand more. We need to understand how we can harness their benefits to the immune system by incorporating them into other foods. And I really think the potential of them is really only beginning. And we have a long way to go to fully exploit the potential benefits of these in lots of different food types. So thank you so much for listening to my presentation today.
Muchísimas gracias, profesora Christine. Ha sido una maravillosa fotografía del sistema inmunológico con nuestro microscopio puesto específicamente en las células T y cómo esa supresión del ambiente gastrointestinal, por supuesto, trae todos estos beneficios sobre la tolerancia. Y como tú bien lo dijiste, es empezar por el final, entender qué significa la tolerancia y, por supuesto, ver los avances en la inducción de esa tolerancia. Tradicionalmente nos hemos ido al modelo clásico de restringir la proteína que está generando la respuesta, pero nos has dado muchas ideas sobre cómo vienen estos avances en la inducción de la tolerancia. Ha sido maravilloso. Esta es nuestra tercera sesión en este curso de RASH. Recuerden que contamos con el aval de Compedia y puntos de certificación. Para obtener los puntos deben ver todas y cada una de las 4 sesiones, ya sea que nos vean en directo o las grabaciones, y contestar una prueba de conocimiento sobre los temas que hemos desarrollado en estas sesiones para obtener sus puntos. Recuerden que a partir de mañana la grabación de esta sesión estará disponible toda la semana hasta la sesión del próximo martes a esta misma hora, y en la última semana tendrán disponibles las 4 sesiones para que se pongan al día. Si quieren repasar más los conceptos, si quieren ver más del 2FL, de la lactancia materna, de la protección contra la alergia, de los oligosacáridos de la leche humana, todo lo van a poder repasar ahí. Así que vamos a continuar, y en esta segunda parte de la sesión de hoy tengo el gran placer de invitar a la doctora Montserrat Álvaro. Ella misma se va a presentar, pero vamos a dar un paso más para que conversemos sobre la terapia inmunológica en alergia alimentaria. Hay diferentes estados de alergia, diferentes estados en la inmunoterapia. Pueden haber contraindicaciones y es importante que lo conozcamos bien, y sobre todo cuál es la eficacia y la adopción a los tratamientos de inmunoterapia. Así que muchísimas gracias, profesora Montserrat. Bienvenida, adelante.
Montse Álvaro. I am a pediatric allergist. I am working in a pediatric hospital in Barcelona, which is called Hospital de Sant Joan de Déu. I am a consultant, teaching and research coordinator in the pediatric allergy and clinical immunology. And thank you very much for this invitation, and thank you very much for being here with us. These are my disclosures. And these are the objectives of my presentation. I want to discuss indications, efficacy, and safety of food allergy immunotherapy treatment. And also I'm going to try to identify novel formulations that may improve efficiency and adherence to this new treatment. And my first thought is that food allergy is really a big problem. It's a worldwide problem of pandemic dimensions. It is calculated that 8% of the children and 3% of the adults can have a food allergy. And lately, the inpatients have been increasing with anaphylaxis, although we haven't had more deaths because of that anaphylaxis. So it's a big problem. And then there's only currently unaccepted treatments, which is avoidance and rescue medication. But if we think, is that enough for our children? Do we think that our children will be safe only with avoidance and rescue medications? My thought is no. This is not enough. So do we need oral immunotherapy? if we think about it, is avoidance effective? Do food allergy patients on avoidance diets stay safe? Do they stay happy? Do they grow well? Do they develop tolerance? There is an impaired safety, and I really think that avoidance is not effective. Why? Well, strict avoidance is very difficult. Main food allergens are ubiquitous. Contamination is frequent. Also, labeling can be poor and sometimes very confusing. We have the problem of the precautionary labeling. Also, careful with the takeaways, the bakeries, there is a big problem. And also with our children, and especially teenagers, constant vigilance is unfeasible. So avoidance is not effective. And also, these patients are at a very high risk. Also, very important is about the quality of life of these patients. They have anxiety because of probable accidental reactions. There are lots of limitations in diet and social life. There is an emotional impact. There is bullying, which is very important in our children. We must fight against bullying, and this is one of the main causes of bullying. Also, they have an impaired diet intake with reduce of calcium, micronutrients, macronutrients. Their nutritional state is not perfect. In patients with milk allergy, weight is low, height is low, and also all these problems related to nutrition. So if we think about it, if we ask ourselves if avoidance is effective and if food allergy patients on avoidance diets are safe, are happy, grow well, develop tolerance, definitely my answer would be no, they are not. Oral immunotherapy is a valid approach for patients who have not achieved spontaneous tolerance. The repeated exposition to the allergen can modulate immune responses, and the probability of achieving tolerance to a specific food is higher in patients after oral immunotherapy if we compare with those on an elimination diet. Which is the main objective of oral immunotherapy? It is to achieve enough desensitization in order to prevent anaphylaxis with the consumption of increasing or gradually increasing amounts of the allergen. This desensitization will be induced in as high as 65 or even 90% of the cases, so it's very important. Which are our goals? The primary goal of oral immunotherapy is to induce non-responsiveness of the immune system when re-exposed to the allergen by inducing immunomodulatory responses, which suppress the allergic response. This can result either in desensitization or sustained responsiveness. And let's talk about these two positions. When we talk about desensitization, what do we mean? We mean that there has been a change in the threshold dose of an ingested food allergen, which is necessary to cause allergic symptoms. And this state will be dependent on the ongoing antigen exposure. And what does sustained responsiveness mean? It means an induction of long-term immunological changes associated with the ability to ingest that food, that specific food, without eliciting any symptoms and without the ongoing therapy. So they are two very different concepts. following on with the oral immunotherapy goals, first thing we should do is a food challenge to really know if still that child, that adolescent is allergic to that food. If that food challenge is negative, end of the problem, our patient will be tolerant, and that's the perfect situation. But usually that oral food challenge will be positive, and our patient will be allergic. Which option do we have then? No intervention, which means avoidance of the food with the rescue medication we were talking about in our first slides. This always has to be talked with the parents. What do they prefer if we think they will be adherent to the treatment? And then we can decide to make an intervention along with the parents. Then after that intervention, we will reach the child will reach the desensitization, and we can then think about stop giving the food after 4 to 5 years of treatment. What can happen if we stop giving the food? We can have two scenarios. After we stop the food and we stop it for 6 to 4 weeks, as much as 2 months, then we can perform again a food challenge and see what happens. If that food challenge is again positive, then desensitization we have reached, we are going to lose it. This is lost. But on the other hand, if that food challenge is negative, then we will reach a sustained unresponsiveness, which is what we are looking for in the last minute. Anyway, even if we reach, if we have again the loss of desensitization, or if we reach the sustained unresponsiveness, we should follow those children, those adolescents in a long-term basis. So we must learn that it is not the same if we talk about tolerance, which is natural, if we talk about desensitization, or if we talk about sustained unresponsiveness. When are we going to use oral immunotherapy? We're going to use it for IgE-mediated food allergy. And this consists on an updosing phase in which we give our patients very small doses until a high enough dose is reached. After that, that high dose or enough dose is reached, depends on the patient. We can have patients, for example, with milk who can reach 200 milliliters maintenance dose, and that's the ultimate goal, and that's very nice if we can reach to that point. But some patients will only be able to reach the, for example, 20 milliliters dose, but that at least will make them more sure, make more safe in their daily lives. Then after that high dose is reached, we will have a maintenance dose in which that specific dose will be given to them daily. If we ask ourselves the question, is oral immunotherapy effective? In these studies, we can see that if we compare the experimental treatment against the control ones who haven't undergone that treatment, clearly using oral immunotherapy, it is 7 times more likely to pass the final challenge in that group than if we compare with controls. The same happens with peanut, and the same happens with egg. So really, this is a very effective treatment. But there are some cons and some pros, same as in every treatment. If we talk about efficacy and effectiveness, the pros is that this is really nowadays the only specific treatment for food allergy, where we can find an increase of the allergen reactivity threshold. Very often the sensitization is achieved, while not so very often sustained and responsiveness is achieved, although it can be. And nowadays we are talking about also using biologicals to help this treatment. But there are some cons in oral immunotherapy, as there's a lack of standardization. There are many different protocols which are used worldwide, so it's difficult to state exactly what treatment we are going. It also depends on the patient, so it's not only what we believe it's the best thing to do, but also on the response of the patient. Also, an uncommon is there is no demonstrated efficacy in adults, and also in children and adolescents, there only has been demonstrated efficacy for cow's milk, egg, and peanut allergy. Most of the time, sustained unresponsiveness has not been demonstrated. And one main problem is that there is a lack of biomarkers of efficacy of this treatment. The data, I can tell you some data in all the publications, in our own experience on efficacy. There is a high desensitization rate. But what happens with safety? Safety is our main concern, as allergic events in oral immunotherapy are an implicit risk, which are suffered by most patients. And although usually they are mild and passing, sometimes gives way to withdrawal of the treatment. Also, we must take into account that in some serious, no high-risk patients are admitted, patients with asthma, patients with anaphylaxis, with high specific IgE. Sometimes they are not admitted to this treatment. So the studies are various, and sometimes we cannot compare between them. But the less studied areas are safety, especially in high-risk patients, and also the usefulness of clinical and immunological data to predict safety. I can tell you about some of our studies. This is a state-of-the-art study in 76 children who were following our protocol on oral immunotherapy for milk allergy. And as much as 95% of our patients had reactions, although if we look closer to it only represents 6.6% of the doses which we administered. So really, there's a high rate of adverse events, but not related with the high amount of doses that we administered. The more frequent adverse events were grade 4 events, more usually bronchospasm. It was the more frequent one with milk. 9% were multisystemic. So some children needed adrenaline, and one child had a near fatal reaction. Also, we must take into account the cofactors which were important in 47 children: exercise, infection, stress, wheezing. So we must be very precise when we give the doses, and we must instruct very well the parents of the doses they give at home are in all sorts of safetiness that sometimes is difficult to achieve. Also, we made a study with egg, oral immunotherapy with egg, comparing with a control group in which we didn't have any intervention. In that control group, only 16% of the children had accidental reactions, and they were grade 1 and 2. While in the active group, 90% of the children have adverse events, which means, again, the dose for reaction was much lower. It is around 7% of the doses given. In relation to egg, most of the reactions were grade 1 or 2, and they were gastrointestinal reactions. And again, ecofactors played a role in those reactions. In fact, 26% of our children required adrenaline, and there was one case of severe reaction with hypoxemia and hypertension. So the remarks I want to make, oral immunotherapy is less safe in children with higher severe reaction after low doses, in which cow's milk allergy or hen's egg allergy are more persistent, while oral immunotherapy is safer in children with less risk of severe reaction with low doses, in which those allergies are probably transitory. But if we think about it, probably the first ones are the ones who most deserve it, as they are in risk in their real lives. So studies are needed. We need new strategies to improve safety in those high-risk children, and maybe with hypoallergenic molecules, maybe with anti-IgE therapy or other biologicals, maybe with other kind of immunotherapy like sublingual, epicutaneous. We are going to talk about it later on. And we must think also on the quality of life impact, the nutritional impact, and also the commitment. This is very important, the commitment of the patient and the family, and also, of course, the economic costs. And again, in relation to safety, we can find pros and cons. The pros would be mainly the reactions are mild if you follow oral immunotherapy. There is a low risk of anaphylaxis. The gastrointestinal, long-term gastrointestinal complications are rare. And again, talking about biologicals, which may improve safety. On the other hand, we have the cons, where sometimes we can think that adverse reactions are frequent and they may include anaphylaxis. And if we talk about long-term gastrointestinal complications, eosinophilic esophagitis is a possible complication, and we must always look for it and be very careful with it. There are poor data on long-term safety, and again, with biologics, they have a protective role, but when should we stop with them when we had achieved the sensitization state? And that's a big problem with this very expensive treatment. So we must look for the lesser of two evils. The risk of allergy immunotherapy is a potential risk, while if the patient is on allergy immunotherapy, the risk of having an adverse event is almost certain, while the risk of allergen immunotherapy is uncontrolled, while if they are on allergen immunotherapy, it's a controlled risk. In the first case, if they are not following any treatment, this is pointless. While establishing a treatment and immunotherapy, it really is meaningful. And the risk where they are not following the treatment is unavoidable, while the risk of adverse events if we administer that treatment is a iatrogenic problem. So we must think about it and try to know which would be the best way. What do the ACLI guidelines tell us about allergy immunotherapy? They tell us that trials have found substantial benefit for patients undergoing oral immunotherapy or even sublingual immunotherapy with respect to efficacy during treatments, particularly to cow's milk, hen's egg, and peanut allergy. And a benefit post-discontinuation is also suggested but not confirmed. Also, taking into account this current evidence, this therapy should only be performed in research centers or in clinical centers with an experience in food allergen immunotherapy. This cannot be done anywhere. There are many treatment risk modifiers, like the different protocols if we administer medication, talking about biologicals as we have done, the setting, if there are inpatients, outpatients, home-based, the different routes, we are going to talk about them now, oral, sublingual, epicutaneous, and some others, the aim dose, low dose, high dose. So they are so very different variables which may change the perspective of this treatment. And if we compare oral immunotherapy with sublingual immunotherapy, they are two different routes for food allergen-specific immunotherapy, and they differ in everything, in the dosing schedule, in the daily maintenance dose, in the efficacy and safety profile. Oral immunotherapy is considered to have a higher efficacy in inducing desensitization, but of course it carries a risk of anaphylaxis and EOE, and requires significant lifestyle modifications. Then combining this oral immunotherapy with biologics such as omalizumab nowadays, or dupilumab, or probiotics, maybe we can improve that way the risk-beneficial ratio. But the big advantage of sublingual immunotherapy is the safety profile, particularly in low risk of anaphylaxis, very few adverse gastrointestinal adverse events, and there have been no reports on EOE as adverse event. So it may be an option for vulnerable patients, but we need more research on that. Also, if we compare sublingual immunotherapy with epicutaneous immunotherapy, while sublingual has demonstrated a modest desensitization but excellent safety profile, and we need more study, as I had also already said, and the epicutaneous immunotherapy studies have demonstrated also a modest desensitization in children younger than 11 years, with also an excellent safety profile and adherence rates. So sublingual and epicutaneous immunotherapy methods could serve as an alternative treatment options for in this case, peanut allergic patients who are unable to tolerate oral immunotherapy. So there are so many sources of heterogeneity in this clinical research we are much needed in the design of the protocols, in the safety outcome measures, in the efficacy outcome measures, and also comparing, we should compare clinical trials with real life experience. So my conclusions and perspectives: oral immunotherapy is effective in inducing desensitization, but not now, still not now in reaching sustained responsiveness. We need more studies. We know that successful oral immunotherapy improves quality of life, which is very important, but safety is the main concern and limits the clinical routine practice. And we also know that oral immunotherapy is unsafe in children with more severe food allergies, so new strategies should be investigated to improve safety, and we're going to talk a little bit about them, but we believe, and IACI believes, that this treatment is not ready for clinical routine practice yet. So there are, or we can see in the future, pathways to better diagnose and treat for food allergy with mechanistic and diagnostic data at a cellular and humoral level, which may contribute in the future to develop precision medicine tools based on sophisticated algorithms or machine learning to diagnose and or predict treatment outcomes. And this is the future, and we must look into it. And also all the future perspective, experimental immunological markers in conjunction with clinical determinants such as lower age, maybe, and lower initial specific IgE appear to be of benefit in immunotherapy outcomes. We need more research on the optimal dose preparation and route of application. Integrating a high-level safety and efficacy is demanding an alternative, or as well as we can use biologicals which can block any of the pathways which takes to allergy. And thank you very much for your attention.
Muchísimas gracias, doctora Montserrat, por tu mirada crítica desde la perspectiva clínica para todo lo que tiene que ver con la terapia inmunológica. Un balance, el equilibrio que nos estás mostrando entre los pros y los contras es fundamental, sobre todo pensando en desensibilización versus no presentación de una respuesta sostenida, pero también dándonos mucha información sobre lo que representa el riesgo implícito de reacciones, incluso para pacientes que no son de alto riesgo. Entonces, ha sido fantástico, creo que es un aterrizaje bastante bueno de lo que podemos hacer en la clínica con muchas cosas, y ya lo dice aquí, todavía faltan algunas cosas para poderlo aterrizar a la clínica de rutina. Y para cerrar nuestra sesión de hoy, quiero invitar en este momento a la transmisión al doctor Benjamín Cepeda para que discutamos algunas de las muchas preguntas que tenemos en el chat hasta ahora. Así que bienvenido de nuevo, querido amigo Benjamín, ¿cómo estás?
Gracias, Oscar, excelente, extasiado con estas dos presentaciones magistrales.
Ha estado, creo que nos ha puesto un nivel muy alto porque al final nos está haciendo un llamado de lo que hacemos en el día a día a la práctica, y por eso creo que estos minutos al cierre de la sesión de hoy van a ser bien interesantes, porque queremos entender un poco más desde la perspectiva de la práctica general, desde la pediatría, desde la gastroenterología, desde la nutrición, qué pasa en la alergia, en la inmunología clínica en particular. Entonces voy a empezar con algunas preguntas. Mira que, por supuesto, aquí hay una pregunta sobre los síntomas. Los niños que presentan síntomas respiratorios, cualquiera que sea el fenotipo, sin síntomas gastrointestinales, claro que sí, por supuesto puede ser la manifestación de alergia. Y en eso, ¿qué tienen que ver, amigo Benjamín? Y aquí te hago la pregunta, los antígenos, porque estamos acostumbrados en la práctica a relacionar el antígeno alimentario con la manifestación digestiva. Pero ¿qué pasa con los otros antígenos, contacto, respiratorios y las otras manifestaciones de alergia? Y puede un niño teniendo solamente síntomas respiratorios en ese panorama de marcha alérgica, ¿puede tener una alergia a las proteínas de leche de vaca?
Excelente pregunta. Fíjate que hasta un 15-30% de los pacientes pueden tener solo manifestaciones respiratorias, y esto puede ser como rinitis alérgica o como asma. Lo más frecuente es que inicien con problemas a nivel de piel. 90% de los pacientes inician con dermatitis atópica y un 60% de los pacientes tienen manifestaciones a nivel gastrointestinal, y es como el abanico más amplio, que pueden ir desde problemas como es el reflujo, un vómito persistente o una regurgitación nada más, cólico, diarrea con sangre, o podemos irnos a estreñimiento. Entonces, es muy frecuente que cuando solamente las manifestaciones son respiratorias, tardan un tiempo en hacer realmente un buen diagnóstico para ver si es el alimento o no, porque no es lo primero que se sospecha. Es más frecuente que en el día a día se sospeche en un alergeno ambiental, intradomiciliario o un polen de árbol, pasto, maleza, pero es bien difícil que lo asocies con el problema de la alergia alimentaria, ¿no? Y esto es bien importante. Entonces, tenemos que hacer una muy buena historia clínica. Creo que la base de esto, cuando llegan los pacientes, es qué asociación tiene, qué le pasa, qué síntomas presenta, y si la mamá es observadora, sí te lo puede decir desde las primeras etapas. Yo asocio que come algún alimento y lo presenta, ¿no? Eso es algo bien importante.
Sí, además nos lo dijo la doctora Montserrat, que el buen diagnóstico es la base del tratamiento. Y si estamos hablando de estrategias terapéuticas como es la terapia inmunológica, pues al final sí necesitamos ese diagnóstico muy preciso, porque no queremos que las ventajas y las desventajas, siempre es una decisión de riesgo-beneficio. Entonces sí necesitamos un diagnóstico muy preciso. Y en ese mismo sentido, querido doctor Benjamín, hay algunas preguntas un poco antes de ese diagnóstico, y es algunas estrategias nutricionales respecto, y lo hemos discutido en muchos foros, tú y yo estoy seguro que de inmediato te va a saltar la alarma. Ese paciente que tiene historia familiar de alergia, que no tiene ningún síntoma específico, no tiene diagnóstico de alergia, pero tiene los antecedentes familiares, si vale la pena o no, si está siendo alimentado con lactancia materna, pues no tenemos ninguna duda, alimentación ideal, pero si está utilizando una fórmula, la pregunta es, ¿vale la pena utilizar alguna fórmula especial? O sea, ¿podemos dejar de usar una fórmula estándar y utilizar un hidrolizado parcial, extenso? ¿Qué opinión tienes de eso?
Mira, también muy buena pregunta. Creo que lo más importante es identificar al paciente de alto riesgo. Porque si acuérdense que las patologías alérgicas tienen mucho que ver, son patologías multifuncionales, más que multifuncionales, tienen mucho tema a nivel global, ¿sí? Esto es atopia familiar, antecedentes de atopia familiar, la vía por la que nació el pequeño, si fue cesárea o parto, si tuvo o no lactancia materna, que sigue siendo un tema muy importante, el abuso en uso de antibióticos. Entonces, son muchos factores que entran en juego para poder desarrollar este tipo de problemas. Y claro que es importante, aquel paciente con un 70-80 el riesgo de poder presentar la patología. Pero ojo, hay que saber a qué es alérgico, porque no es lo mismo que la mamá sea alérgica a ácaros, a pastos, a que sea alérgica a un alimento, ¿no? Es bien importante no hacer restricciones masivas. Se puso de moda el restringir alimentos de una manera impresionante y los niños te llegan comiendo 2 cosas y la verdad es que eso es lo que no tenemos que hacer. Y si no hay antecedentes de alergia alimentaria, tranquilos, no tienes por qué hacer una restricción, no hay por qué hacer una restricción durante el embarazo, que también es algo muy importante. Y es evaluar al pequeño y ver qué tema tiene y qué síntomas. Si el hermano mayor tuvo alguna sintomatología, sí presentó una alergia como tal, ojo, estoy ante un niño de alto riesgo que sí tengo que estar observando, que yo iniciaría con lactancia materna. Si por algún motivo no se puede hacer o se tiene que dar complementaria, se puede iniciar con una fórmula parcialmente hidrolizada y lo vas vigilando. Es un pequeño que tienes que ir vigilando y esperar si presenta o no manifestaciones. Algo bien importante, Oscar, es que en niños menores de 2 años de edad, el 80% de ellos presentan manifestaciones no mediadas por IgE. Y esto cambia totalmente la evolución, porque acuérdate que las no mediadas se presentan 48, 72 o 96 horas posteriores de comer el alimento agresor. Y las 2 manifestaciones principales de la marcha atópica o marcha alérgica en estos niños va a ser dermatitis atópica o síntomas gastrointestinales. Y hay que hacer una diferenciación muy importante con los trastornos gastrointestinales funcionales, que no estamos hablando de una alergia, que son mucho más frecuentes que la alergia a los alimentos, ¿no?
Sí, totalmente de acuerdo. Y hay otro par de preguntas respecto a prevención de alergia. Vamos a hacer un tema que vamos a tocarlo en la 4ª y última sesión de nuestro RASH, pero al final también hay algunas inquietudes sobre, por ejemplo, prematuros o prematuros extremos recibiendo fórmulas hidrolizadas o extensamente hidrolizadas para para lograr adecuada tolerancia o para prevenir el desarrollo de las alergias o otros riesgos. ¿Qué opinión tiene respecto a esa acción de
Es un buen
prevención, por ejemplo, en prematuros?
en prematuros. Fíjate que el prematuro es un paciente muy sui generis y también igual. Hay estudios en los que finalmente la lactancia materna va a ser lo número uno y las características de la leche materna en niños prematuros son diferentes. Inclusive específicamente hablando de oligosacáridos de leche materna, cambia la proporción y las cantidades de oligosacáridos comparado con los niños a término. Entonces, es muy buena pregunta. Se hizo como una moda de utilizar fórmulas extensamente hidrolizadas para mejorar tolerancia, pero realmente existen fórmulas específicas para prematuros que son las que realmente necesitan y que no necesitas irte a un hidrolizado extenso o a una de aminoácidos porque realmente no tienes el problema de tolerancia, ¿no? Y aquí lo más importante es que se está sumando una patología extra, que es la prematurez, y la prematurez como tal es una inmunodeficiencia secundaria. Acuérdense que en el último trimestre del embarazo, mamá pasa un pool de anticuerpos IgG que va a proteger a este pequeño los primeros 6 meses. Y algo que mencionaba muy importante la doctora durante esta parte de la tolerancia, recuerden que el bebé viene de un ambiente TH2, donde mamá tuvo que bajar su respuesta para tolerar a este bebé que está gestándose, porque 50% del contenido no corresponde a ella. Entonces, si se pusiera de una manera muy agresiva, pues no llegaría a término este embarazo. Entonces, el paciente prematuro es un paciente sui generis, porque aquí lo que estamos viendo es algo agregado a una patología y realmente no hay estudios en los que se ve que prematuros tienen mayor riesgo de problemas alérgicos, ¿no? Se van sumando otros factores. Pero creo que ahí el uso de lactancia materna sí o sí va a valer la pena y si es necesario, una fórmula para prematuros sería la indicación en ellos.
Sí, es muy importante lo que tú dices, resaltar al final que el prematuro, claro, tiene una permeabilidad intestinal aumentada y eso puede generarse teóricamente algún riesgo de sensibilización, lo cual no necesariamente implica manifestaciones alérgicas al 100%, pero que el prematuro sí es un caso especial en el que hay requerimientos nutricios muy particulares. Y al final, cuando decimos intentemos una fórmula hidrolizada extensamente o aminoácidos, hay que considerar otros factores como osmolaridad y otras cosas características propias de esas fórmulas que pueden afectar la tolerancia. Entonces, creo que en ese sentido estamos muy de acuerdo. Y déjame saltar, amigo, a terapia inmunológica. Lo que entendemos es inmunoterapia oral, sublingual, subcutánea, pero también, ¿será que podemos incluir ahí, por supuesto, los biológicos? ¿Será que podemos incluir ahí los probióticos? ¿Será que los prebióticos como los oligosacáridos de leche materna, todas estas moléculas en lo que vimos en los avances de inducción de tolerancia, todas estas cosas pueden ser consideradas dentro de este escenario de terapia inmunológica? ¿Tú qué opinas de eso, amigo?
También, pues mira, viene toda una revolución y esto es bien importante. A ver, número uno, no perdamos el objetivo. Primero es hacer un buen diagnóstico y ante el diagnóstico ya real de una alergia, porque en muchas ocasiones nunca se llega a un diagnóstico y se hacen restricciones innecesarias. Entonces, ante el diagnóstico real de una alergia alimentaria, ya que identificaste el alimento o los alimentos que están involucrados, lo primero que tienes que hacer es una dieta de restricción a los mismos, por lo menos de 6 meses a un año. ¿Cuándo se utiliza esta inmunoterapia? En los casos graves, si bien lo decía la doctora Álvaro, hay pacientes, y la inmunoterapia la vamos a utilizar en pacientes con alergia mediada por IgE, que son los que tienen riesgo de hacer anafilaxia, ¿no? Afortunadamente, alimentos de buen pronóstico van a ser proteína de leche de vaca, proteína de huevo, les va muy bien, haces una restricción de 6 meses, un año, lo ideal es llevarlos a un año, y cuando haces los retos les va bastante bien, pero ojo, nuestro objetivo de cuidado es el paciente que ha tenido intervenciones con el alimento y que te ha hecho una anafilaxia. Anafilaxia, recuerden que es el caso más grave de una alergia que pone en peligro la vida y que tienes que tener mucho cuidado con estos pequeños. Afortunadamente, la prevalencia de anafilaxia no es muy frecuente en la población general. Sin embargo, después de que pasa un cuadro, tienes que estar muy pendiente de ese pequeño porque puede estar expuesto a este alimento de una manera accidental, que es lo que mencionaba mucho la doctora Álvaro. Entonces, sí, aquí se abre mucho las terapias que hay actualmente. La inmunoterapia oral, que es lo que nos habla la doctora Álvaro. Europa fueron los pioneros en esto y la verdad lo que se hace es utilizar pequeñas cantidades de leche cocida, de leche que esté caliente, calentada, pues, para que no se desnaturalicen las proteínas, y es una manera de que presenten menor reacción a la misma, pero sobre todo en los pacientes que tuvieron alguna reacción grave o que pueden tener tendencia a estas reacciones alérgicas, para que no tengan situaciones de riesgo. La conocemos, la inmunoterapia, desde hace mucho tiempo, tanto sublingual como subcutánea, para alérgenos inhalados, y tenemos más de 100 años utilizándola, y es un tratamiento muy seguro, es un tratamiento que cambia la historia natural de la enfermedad, y en los pacientes que tienen manifestaciones respiratorias llegan a un control muy importante de los síntomas, y es lo que se ha querido traspolar a los pacientes con alergia alimentaria. Pero como bien decía, no todo se puede, no es para todos, no es algo que se hace de manera rutinaria, y han entrado de la mano otros productos como son los biológicos, como son los monoclonales, y en este caso omalizumab y dupilumab, que acaba de tener la indicación para esofagitis eosinofílicas, son dos alternativas muy importantes que podemos tener de la mano para estos pacientes. Ojo, el tema económico sigue siendo una limitante para muchos de estos pacientes, pero son alternativas que tenemos ya reales para utilizarlo. Y en el caso de pre y probióticos, excelente pregunta. La evidencia que existe hasta ahorita real en cuanto al uso de probióticos no tiene un resultado contundente que sean la opción. ¿Por qué? Porque las cepas son muy diferentes, no todas son la misma, no todas las cantidades son la misma. Entonces, la evidencia todavía es muy pobre para poder hablar de que un probiótico va a ser la alternativa. Sin embargo, sí nos ayuda a mejorar estas disbiosis que tenemos en estos pacientes. La alergia es una disbiosis, y entonces tenemos que todavía seguir viendo qué investigación va a haber acerca de esto. Y algo que está abriendo el panorama son definitivamente los oligosacáridos de leche materna, en los cuales estamos viendo en todos los estudios preclínicos y ya en los estudios clínicos que sí están ayudando, sobre todo si pusimos mucha atención, nos habla precisamente el efecto que tienen con estos linfocitos T reguladores, que al final son los que nos van a ayudar a generar esta tolerancia, y que estos estudios vienen evidentemente de estudios hechos con lactantes en leche materna, y cómo disminuyen el riesgo. Finalmente, si sabemos que esto es multifactorial, tenemos que tener alternativas para poder ayudar a los pequeños, y lo que sí está abriendo, yo creo que el camino, y los próximos años tendremos la evidencia ya mucho más palpable, es sobre todo con el uso de oligosacáridos de leche materna.
Perfecto, y con eso creo que es una buena respuesta para muchas preguntas que habían alrededor de probióticos generales, probióticos recomendados en niños ya con historia de atopía, probióticos en inmunoterapia específicamente, tratamientos específicos de probióticos como inmunoterapia, mucho interés respecto a lo que son estos alimentos funcionales de pre y probióticos, y creo que has trazado de forma excelente la línea hacia dónde va la investigación y qué cosas podemos hacer basados en la evidencia. Hay algunas preguntas de inmunoterapia también respecto a lo que ya mencionabas, querido doctor Benjamín, sobre la factibilidad por recursos en nuestros países de decidir si la inmunoterapia es específicamente para proteínas de leche versus otras proteínas de alimentos, si es específicamente para mediada o no mediada por IgE, si hay diferencias en lo que es sublingual versus oral. Y sobre todo me quedo con lo que ha dicho la doctora Montserrat respecto a que incluso de aquí, los europeos tienen toda la experiencia en el uso de la terapia inmunológica, pues todavía no dan el paso a recomendarla como parte de la rutina clínica usual. ¿Qué opinas digamos, de ese uso, o cuándo, si ya estamos en uso, vamos a retirarla? ¿Qué opinas, doctor Benjamín?
A ver, sí, la inmunoterapia se utiliza para patologías mediadas por IgE, ese sí es el tema. Y evidentemente la oral, que es la que se está utilizando en pacientes con alergia alimentaria, y es ir aumentando gradualmente la cantidad de alimento al cual los pacientes son alérgicos, para ver qué tolerancia tienen. Si no es algo que se utilice de rutina, sí es una gran alternativa, sobre todo en estos casos donde podemos llegar a tener casos graves. La gran ventaja creo que aquí el punto medular es hacer diagnósticos tempranos, Oscar. Si nosotros hacemos diagnósticos tempranos, que esa era la otra pregunta del millón, ¿hasta cuándo saber o cómo puedo yo saber si un paciente es alérgico, no? Resulta que cuando estudiamos medicina nos decían que nos teníamos que esperar hasta los 5 años. Cuando estudiamos pediatría, que nos teníamos que esperar hasta los 2 años.
2, 3.
Actualmente sabemos que tú puedes, ¿no? Tú puedes saber desde que un pequeño a la semana de vida, al mes de vida, a los 6 meses está con manifestaciones, tú puedes saber qué problema tiene, si es un problema alérgico y se pueden hacer los estudios, que creo que es lo más importante, porque a partir de aquí podemos hacer una supresión del alimento agresor y entonces le va a ir mejor el niño antes de los 5 años de edad. Y si se dieron cuenta, lo que comentó la doctora Álvaro es muy importante. Al niño le va mucho mejor que al adulto. El problema es el niño después de los 5 o 6 años que no toleró el alimento agresor, va a tener mucho tema con este tipo de problema y entonces no va a poder estar en contacto con estas proteínas. Entonces, lo medular es hacer un diagnóstico temprano. Ya que tengo el diagnóstico, hacer una restricción del alimento y posterior a un año retarlo. Y la gran ventaja, yo creo que un 70-80% de los pacientes mejoran mucho, ¿no? Y sobre todo con lo que es leche y huevo. Recuerden que el alergeno número 1 a nivel mundial son proteínas de huevo, número 2, proteínas de leche de vaca, pero en menores de 2 años, la proteína de leche de vaca es el alergeno número 1. Entonces, creo que primero hagamos un buen diagnóstico, no sobrediagnostiquemos, que también eso es bien importante, y claro, en aquellos pacientes que ameriten el uso de esta inmunoterapia oral, se va a hacer y sobre todo porque vamos a evaluar, y lo dijo muy bien la doctora Álvaro, se habla con los papás y si no se logra un buen control de estos pacientes y tienen mucho riesgo de tener exacerbaciones por accidente, ojo, es el paciente ideal para poderlo hacer.
De acuerdo, muy bien. La alergia a las proteínas de leche de vaca tienen una mejoría temprana, pero pues eso nos limita muchísimo en cómo medir factores de tolerancia en particular. Y como tú bien lo dices, la intervención oportuna con ese diagnóstico adecuado en alergia puede prevenir otras manifestaciones. Entonces, tenemos una tarea muy importante ahí. Déjame despedirnos con una pregunta bien interesante. Paciente lactante que tienes con diagnóstico de alergia a proteínas de leche de vaca, no está siendo alimentado con leche materna, tienes que cambiar la fórmula a una fórmula especializada. Tu opinión, fórmula hidrolizado extenso con base en proteínas de leche de vaca versus proteína de arroz, por ejemplo, las fórmulas que tenemos en los mercados de muchos de nuestros países.
Muy buena pregunta. Fíjate que lo más importante es tener un diagnóstico, porque tú puedes ser alérgico dentro de las proteínas de la leche de vaca, podemos ser alérgicos a caseína o podemos ser alérgicos a proteínas de suero, que es alfa-lactoalbúmina o beta-lactoglobulina. Sabemos que el 70-80% de los pacientes están sensibilizados a beta-lactoglobulina. Entonces, en el mercado tenemos fórmulas extensamente hidrolizadas de suero o de caseína. Entonces, desde ahí tú ya puedes tener una gran alternativa y saber que obviamente vas a tener más tolerancia a las fórmulas extensamente hidrolizadas de caseína. El problema es cuando el paciente es alérgico tanto a proteínas de suero como a proteína que es la caseína. Entonces, ahí automáticamente las fórmulas extensamente hidrolizadas no son una alternativa cuando son de proteína de leche de vaca. Y lo que son las fórmulas vegetales, como es el caso de la proteína de arroz, es una gran alternativa porque tenemos como tal los aminoácidos del arroz. Se le agregan los aminoácidos que hacen falta. Sabemos que la calidad biológica siempre de una proteína animal va a ser superior a la vegetal. Pero en el caso de las fórmulas que se utilizan de proteína vegetal en pequeños, están fortificadas, están añadidas con vitaminas y minerales que necesitan y evidentemente también ya están con, empieza a haber ya estudios para también agregarles oligosacáridos de leche materna. Entonces, esta es la alternativa. Y ojo, no confundir las fórmulas vegetales con bebidas vegetales, que no son leches y que no están fortificadas y que no tienen la cantidad proteica y de nutrientes que necesitan los pequeños, que también se empezó a poner muy de moda el uso de estas bebidas vegetales. Entonces, y bien nos decían las guías, nos lo explicó el doctor Fiocchi cuando tuvimos la segunda sesión, bien, está muy claro que entra ya como una gran alternativa de tratamiento en estos pacientes las fórmulas hidrolizadas de arroz.
Muchas gracias, querido amigo. estamos ya sobre el final de nuestra tercera sesión de Rash. Siempre un placer compartir contigo. De verdad que las presentaciones de hoy han sido fantásticas. Simplemente un reconocimiento a casi los 1000 colegas y amigos que están conectados en directo a nuestra sesión de hoy. Recuerden que contamos con el aval de Compedia y los puntos de certificación y que para eso tienen que ver las cuatro sesiones que tiene nuestro Rash y además de eso rendir una evaluación. A partir de mañana van a tener esta sesión grabada para que la puedan repasar toda la semana y el próximo martes a esta misma hora tendremos la cuarta y última sesión y a partir de ese día van a tener todas las 4 sesiones disponibles para que se pongan al día y puedan tomar sus notas y volvernos a ver on demand para que luego tomen la prueba. Muchísimas gracias y te dejo, querido amigo doctor Benjamín, para que despidas la sesión de hoy.
Excelente, muchas gracias, Oscar. Pues fue una sesión totalmente satisfecha, fue una sesión de gran ayuda para todos, de mucha información que creo que nos deja este paradigma mucho más claro y que podemos saber que el paciente alérgico tiene obviamente un momento muy importante para hacer el diagnóstico, que podemos evaluarlo y que podemos tener alternativas de tratamiento y lo más importante es hacer diagnósticos tempranos. Agradezco mucho a todos los más de 1000 participantes. Creo que este curso ha generado una gran retroalimentación para todos y gran interés por parte del grupo pediátrico y del grupo médico, y eso es encantador porque vale la pena el tener esta educación médica continua de manera persistente. Y agradezco que estén conectados. Falta una sesión más. Recuerden ver las 4 y contestar en la última sesión nuestro cuestionario. Y recuerden que los espero del 10 al 13 de julio en Sintermex Monterrey, en nuestro 31º Congreso Compedia 2024. Seguirán hablándose mucho de esto y mucho más que hay para los pacientes alérgicos. Ahí nos vemos y gracias a todos por estar conectados.
Ahí estaremos.
Un abrazo.